in this left ear. So he's got a collapsed ear canal. And when you see the right ear, after we've completed this, the left ear, the ear canal entrance is completely collapsed. It's completely shut and it's completely sealed. And I'll talk you through how we approach that ear and how we manage to insert not only the endoscope but the suction probe into the ear, given that the ear canal is completely shut and closed and collapsed. And I just managed to remove the outer lateral plug of dead skin, keratin, and it's combined a bit of earwax as well. Now this patient's got a very narrow bendy ear canal too, and you may see here the ear canal bends to the right and then to the left, so this is the second bend. And to get access, and this is a good one for the clear wax delegates that have come on the course, if you remember when we're performing the procedure in the left ear, we're using the endoscope to stretch open the ear canal to the right. So we're looking bottom right of the ear canal around 4 or 5 o'clock. That opens up the ear canal, enables me to then use the suction probe to push the cartilage also to the right and then insert it straight into the ear canal, which has, as you can see, enabled me to remove this skin plug. So what's a collapsed ear canal? The outer third, I'll just come back to the moment, so I'll just explain the patient's eardrum. So that's the patient's eardrum that's visible. You can just see the chorda tympani there as well. The chorda tympani is the nerve of taste, and it runs just behind the eardrum, adjacent to the hammer bone, the malleus. So a collapsed ear canal is when the outer part of the ear canal, the cartilaginous portion, the cartilage can either over time, just due to gravity, collapse upon itself. A bit like some people's the tip of their nose, because the tip of the nose is made up of cartilage, whereas the top part of the nose is made up of bone, so it's more solid. The scaffolding of the nose is more secure with the bone. And similarly with the ear, the outer part of the ear is made up of cartilage that can weaken over time as we age, and gravity just collapses it. So the back part of the ear canal, the posterior cartilage, can collapse and just rest on top of the anterior portion of the cartilage. Clear the ear canal. Patient's got otitis externa, as I mentioned earlier. Otitis externa, it can mean many things, but the generic definition of a otitis externa, the term otitis means ear infection, and externa relates to the location of that. So externa is the external part of the ear, the outer ear, so from the entrance, and even the satellite disc, the pinna, so the cartilage that we see externally, that consists of the outer ear, up to the outer membrane of the eardrum. So that's the left ear done. Before I go to the right, you can just see I've annotated where the chorda tympani nerve is. Now this is the patient's right ear. As I explained at the beginning, the canal entrance is completely shut. Cannot see at all inside. However, what we do, we stretch open the ear canal by pulling back the pinna, so the satellite dish on the outside, backwards and upwards. And by doing that, not only do we straighten the first bend of the ear canal, so it's in line with the second bend, by lifting it up, it also, most people's ear canals, you have an upward trajectory around 30 degrees, so by lifting it upwards as well, we straighten the base of the ear canal, so we're not no longer looking up and over the ear canal. By lifting the cartilage up, the ear canal becomes horizontal, and by stretching it back, it becomes straight. So it becomes just like a tube of Smarties almost. It's a straight cylinder. Now, to keep the ear open once we've stretched it back and up, we then use the endoscope, believe it or not. And again, the endoscope goes in the case of the right ear, we're just leveraging the endoscope to the bottom left, so southwest of the ear canal, and we actually apply some pressure on the cartilage, and because it's the cartilaginous portion, it's not uncomfortable for the patient at all. And I always explain it to the clear wax delegates, we're using the endoscope as a doorstop. So we stretch the ear open, insert the endoscope, keep the jaw ajar, and then we can then go in with the instrument. So you can see from that completely collapsed ear canal entrance, not only are we getting a 2.7 millimeter diameter endoscope in the ear, but we're also, at the same time, also inserting a 2.2 diameter suction probe, dissolving suction probe. So again, the patient's got otitis externa, and because the canal entrance is as I said, collapsed much more than the left ear. As I'm extracting this plug of skin, it's getting trapped at the entrance. I'm just opening up the ear again. This procedure is a bit more complex because the ear is a lot narrower as well. Not only is the canal entrance collapsed, but the diameter of the ear canal as we enter and go towards the ear was also a lot narrower. The patient was using drops, but they advised that they felt as though the drops wasn't actually penetrating in their right ear, and that's most likely because the canal was collapsed. People often ask, does that affect one's hearing when you've got a collapsed ear canal? Now, oddly enough, the majority of times, no, it doesn't. So, although to the naked eye it's completely collapsed, there is probably a bit of an opening there to allow sound in. Now, that's for the majority of cases, and it's you would think, wouldn't you, that if the ears collapse at the entrance, that it will cause a conductive hearing loss, so sound can't get into the ear canal. But more often than not, it doesn't. So once I removed the wax from this patient's ear, they felt as though their hearing was just as good as their left ear. In some cases, though, a very small minority, yes, it's so collapsed, it's so sealed that it's not allowing any air or sound waves to enter. And I think I've got on my books around, it's a rough estimate, about 30 to 40 patients with a collapsed ear canal. And I think probably only one or two have a collapsed ear canal to the degree where it does affect their hearing. So they still can hear, but there is some degree of hearing loss attributed to their collapsed canal. Possible remedies for that is typically surgical. Now, if the ear canal is shut because of swelling there, then obviously medication can help to reduce the inflammation. However, if it's just due because the cartilage has collapsed, there's possible myotoplasty, canaloplasty to help stretch open this ear. I think I've only ever seen one patient before my whole career that's had surgery done to open up the entrance of the ear canal. And you can see the eardrum at the distance. And again, once more, patients got otitis externa, a lot of dry skin there. They are on treatments for this. They do suffer from eczema, other parts of the body. They are very diligent. They avoid water in the ears. They wear swim plugs. So even in the right ear, we managed to take some impressions of some swim plugs. So it is a bit of a push in at the entrance of the right ear, but once they insert it, and I said the canal, the cartilaginous portion of the canal has some give because it's cartilaginous, it's semi-flexible, partly malleable, so you can apply some pressure, fit a swim plug in there, and the cartilage will just mould itself around the plug. So just some keratin that's coating the canal wall. I want to remove this because the patient has got a slight attic retraction and I don't want any keratin to get built up in there. We weren't able to remove all the dead skin, not at least from the eardrum. There's a tiny bit remaining, but it was slightly uncomfortable with the patient because the skin there, so you can see the eardrum to the right, you can see that a keratin tail actually from bottom left trailing top right. And that's actually dead skin migrating. People often ask, how does the skin migrate? And it's quite difficult to explain. However, I did give an analogy and someone commented back that it was a useful analogy for them to kind of understand how the skin of the eardrum dies, sheds and migrates. And the analogy I gave was, imagine you have a stone or pebble and you drop it into a pond and you'll get the ripple effect. So imagine where the stone makes contact with the water on the surface of the water of the pond. Imagine that being the centre of the eardrum. Then you get a rippling effect, spiralling outwards. And imagine the keratin off the middle of the eardrum dying, shedding and migrating outwards in a ripple effect, similarly to when you drop a pebble into a pond. And that's what happens with the skin on the eardrum. As it dies and sheds, you have a fresh layer of skin that's secreted underneath. That pushes the dead layer of skin off and away from the surface of the eardrum. That skin then collects keratin, which is a protein, and that keratinous skin then slowly migrates outwards from the centre of the eardrum. It can take around 10 months for it to reach the entrance of the ear, and it's a continuous conveyor belt. So it's about 3 millimetres a month. If you average out the ear canal length to be 3 centimetres, so roughly 10 months, should I say, for the skin that dies off the eardrum to be released out of the ear. So I've removed the majority of skin, and these cases you're never going to get all of it out. I had to bend the tip of the fine suction probe here to get, actually you can see the bend there, just to avoid the anterior canal wall. I'm gently peeling this off. The patient's hearing loss is alleviated. They can hear very well indeed, but I just wanted to see if I can remove as much dead skin off the canal wall and eardrum as possible. And in a minute we're going to have a close inspection of this patient's attic retraction. You can see at the top part the eardrum sucked in due to eustachian tube dysfunction. I think I described that in yesterday's video, the day before, what an attic retraction is. Or there's a video that's labelled cholesteatoma earwax removal. It's one Ella did earlier this week. So if you guys want to know what an attic retraction is, please do visit that video, listen to the audio, and I've explained it in depth. So I did take some off the eardrum. You can see we looked inside that attic retraction. It's nice and clear. Sometimes attic retractions, they are self-cleansing, so the skin doesn't get trapped inside. That's one of the plugs of keratin I removed. I hope you enjoyed that video.